All right. So, hey, thanks everybody for joining us today at what should be a very interesting discussion. I'm Steven Carnovale. I'm a professor of supply chain management here at RIT in the Saunders College of Business. So this webinar series, we do these every year, and they're sponsored by our master's degree in global supply chain management. And given everything that's gone on over the past 18 to 20 months, I'm super excited to have Erich Heneke with us from the Mayo Clinic, who's going to talk about supply chain challenges at the Mayo Clinic and in the broader industry, the impacts that we've seen, the cascading effects of mandates and just rippling chaos, I guess would be the one way to describe it, over the past number of months. So I'll kick it over to Erich. I'll let him introduce himself, and then when he's done, we'll start asking some questions, and should be really nice. Should be really nice conversation for all the participants. If you do have questions, we're going to save a portion at the end because I don't know that we'll go the entire hour, but we'll save a portion at the end for you to either type your questions in or ask them directly. In the meantime, if you would please ensure that your microphones are on mute, that'd be great. And then with that, I'll just kick it over to Erich. Erich, thanks for joining us.
Great. Thanks, Steven, for having me. My name is Erich Heneke. I do work at the Mayo Clinic in the other Rochester, Minnesota, in the supply chain division. I've been there 14 years, all 14 years in supply chain management. And there's a lot of specialties and a lot of focuses and a lot of niches in supply chain. My background is that of an accountant, and so I have an accounting degree and a finance degree, business. And so my position is largely in the financial reporting, risk management space, audit controls. And I sit on the supply chain leadership team at Mayo. So I have a pretty wide view and lens of the entire supply chain division. Our supply chain division is approximately 700 people. You heard that right, 700 people. It's across approximately, we'd be just north of 30 hospitals. Primarily in the upper Midwest, but we also have campuses, a large, what we call a group practice campus in Jacksonville, Florida, and Phoenix, Scottsdale, Arizona. So we service, the three primary main campuses of Rochester, Phoenix, Jacksonville, and then a smattering of small critical access hospitals, again, primarily in Minnesota and Wisconsin. So that's a little bit about myself and my background, and I think we'll probably address some of the other nuances of our supply chain through our questions. So, Steven?
Yeah, that's fantastic. So the one thing I think we should probably set the stage with here is when you've been at Mayo Clinic for a number of years, been in healthcare for a number of years. So let's say I asked you, hey, what's the state of the healthcare supply chain in November 2019 versus what's the state of the healthcare supply chain right now in November 2021? What are you going to tell me? I mean, what's the landscape and how have things shifted, broadly speaking?
Yeah. In November 2019, I think we considered things to be pretty stable, pretty much business as usual. And I think most organizations felt as if they had a pretty strong, sustainable, and resilient supply chain. Now, that being said, and we can talk about this a little bit later, but Mayo, along with partner Spectrum Health up in Michigan, had formed a consortium or collaborative around supply chain resiliency, even before the pandemic took hold. But by and large, most healthcare organizations felt like they were in pretty good position. Now, I'll tell you that in 2019, and this is I think a deep contrast to today, a lot of, if not most, healthcare organizations had a couple of, I think, underlying principles that they operated within. The first one was to get products at the lowest possible acquisition cost. And that's a logical, I think, supply chain management function. The other one, which has caused a lot of chaos in the healthcare supply chain, is the concept of, lean inventory management or just-in-time inventory. And what that basically means is that, you carry little or no inventory on hand of anything. And essentially you are able to acquire those products right at the moment at which you need them. And of course, that's a perfect world, but that's conceptually how it worked. Now, 2 years later, I think both of those paradigms have shifted quite harshly the other direction. And so hospitals that, in that March to June timeframe, or even longer into 2020, had no safety stock and virtually no inventory on hand. And so when we got to the position of needing particularly PPE in 2020, a lot of healthcare organizations struggled a lot to acquire those products. And Mayo was in some ways sheltered and protected because we did have a large cache, particularly of masks. But we, just like a lot of healthcare organizations, did have a hard time acquiring products. Now, 2 years later, most hospitals are saying, well, maybe this concept of lean or just-in-time inventory was short-sighted, and maybe we ought to consider something either carrying more inventory on hand on a larger scale, or some hybrid between lean and carrying warehouses upon warehouses of safety stock. Maybe there's some happy medium that we ought to be thinking about. The other thing is, and you'll not hear a lot of supply chain healthcare professionals admit this, but most at this point in time are probably willing to pay a little bit more for a product, with there being a promise or an assurance that that product will indeed arrive on time and will be available at any point in time. And so we're starting to see a little bit of a shift now with price point, and in a lot of ways that then translates and trickles into where the product is manufactured, which oftentimes means onshoring or something closer to onshore in terms of a manufacturing location. So dramatically different mindset in terms of how the supply chain looks and feels now as opposed to 2 years ago.
And so how much of that feel is induced as a result of the conditions in the environment versus some type of regulations that might have come down? And the reason why I ask is one of my classes did a project with the University of Rochester Medical Center here, where we helped them stock their PPE surplus. And there was a mandate that came down from the governor's office, which said whatever the top burn rate was at the height, I think it was in April of 2020, you've got to keep 90 days of PPE on hand for that. So that's just one example, of course, but so like how much of it is externally mandated versus this is just the dynamic of doing business now, the way we're doing it? Yeah,
I think 90% of it is the dynamic of doing business, and it's an emotional response. I think 2 years ago we were really heavily toward lean, just in time. The pendulum has swung widely the other way. I think it eventually will come back more center, once the supply chain is a bit closer back to normal than it is right this minute. But I think that the long-term impacts are probably that hospitals will on average carry more inventory in the balance sheet and within their warehouse. And I do think that there's probably going to be, well, there already is, a push for the supplier community to respond with regards to what they're doing from a resiliency perspective. And again, this is something that actually for Mayo predated any virus issues or anything related to the supply chain disruption associated with COVID. But now hospitals are insisting on it, even contractually insisting on it through a supplier to say, we would need or we would require X% of our utilization be available to us at any point in time, or just as an example. So I think a lot of it is emotional.
So then, so that sets the groundwork on how things have shifted and all that. The current issues that we're facing typically relate to logistics, right? So squarely in that storage and delivery. What's the impact that your system is feeling with the trucker shortage, or with the warehousing capacity, or with even those ships that are stranded? I mean, what are you guys seeing on a day-to-day basis as it relates to that?
It's bad. It's bad right now. It's probably it is worse now than what the PPE crisis was a year and a half ago. And the reason is because when you look at PPE, it's actually a fairly narrow suite of products that really fall into that category. It's certain protective gear, and it's a fairly short list of products when you really break it down. The problem now is not PPE at all. There's plenty of cash of PPE. The government has enough, hospitals have enough, manufacturers have enough. The problem now is everything else, and you don't really know for sure which product is next to be short in supply. So and this is shocking to me. The one right this week, the product in short supply are crutches. Who would have ever thought crutches would be in short supply? Well, it has to do with metal manufacturing, and there being a shortage of just a pure raw material. I don't remember, titanium or whichever the primary metal is in a set of crutches. So that product that raw material being in short supply has created a manufacturing disruption. The manufacturing disruption is compounded by the fact that ocean cargo ships are on the wrong side of the world right now. They're sitting in the US ports full instead of being in the Asian ports empty. And then what compounds that, of course, is there's no one to take the product off the ship in the port in LA right now. And even if there was, there's not a driver to move the product off of the dock. So there's all of these interrelated types of things that are happening. And as I said, we don't know which shoe is next to drop. We simply can't predict because everything is in such chaos. We can't predict which item is at risk now. So it's really bad. Most, from the patient perspective, most aren't noticing it. There's a lot of stuff happening behind the curtains. For example, the crutches example, I've heard of hospitals going out and doing crutch drives, where they basically say, hey, if you have an old pair of crutches in your closet you're not using, bring them on in, just like they were doing with masks 2 years ago. If somebody can stitch some masks, we'll take them. They're doing that with crutches now. And so the patients, again, the magic is to make sure the patients don't see and feel that pinch, but there's a lot going on right now.
So that kind of leads me into the next question I was going to ask you, which is, what are the surprises in terms of shortage? So crutches are one. Any other surprise shortages that have been popping up that you would have just never expected?
A few, yeah. We have heard surgical gloves for quite some time have been in short supply, and that's a little bit of a mystery, but again, I believe it's a raw material item that's creating some of the issues. Trying to remember what else I've heard lately. IV fluids for a while were a little bit tenuous, but that's been a traditional long-term issue in that industry. The other thing is, and again, it goes to show how interconnected the supply chain is. There's also been issues over the years and recently have gotten worse around facilities that sterilize products for reuse. And this has nothing to do with COVID, actually. It has to do with a governmental regulation that has swept across state by state that essentially the point of the regulation is to eliminate gases that are going out into the atmosphere and causing humans to certain cancers and so forth. And so in some situations, the state governments have actually shut down sterilization facilities. So any sort of product that we as a hospital might send off, sterilize, and have it come back and reuse, all of a sudden are in short supply because, again, it's kind of like the shipping issue off the coast right now. Products are sitting on the dock waiting to be sterilized, and the facility's closed. There's no one there. So like I said, it's just we're waiting for the next sucker punch, and we're not sure which direction it's coming from. It's really, really, really difficult.
So, see, that's kind of the thing that I was going to get at too. Is the thinking about shortages as it relates to the way that you guys think about inventory. So, a shortage for a household with respect to food might be, I've only got enough for tonight. I've got to run to the store and go get some food. What are how are you all thinking about safety stock levels, particularly now? Are you thinking 30 days, 90 days, 120 days, in some cases, as many days as we can get our hands on? How has that shifted? Because you mentioned the transition away from the JIT mentality into we need it now mentality. How have safety stock levels and calculations changed from your vantage point?
Yeah, the concept of safety stock and inventory levels, the just the concept of it in general haven't necessarily changed. What has changed are a couple of things. The number of days on hand, as you mentioned, that's a big one. Whereas we possibly would only have a few days to a couple of weeks of on-hand inventory. Now it's at least for the critical items, is more out to that 90-day safety stock level. The other thing that we've had to do, though, is to really dial in hard on what we consider a critical product, because we manage tens of thousands, if not hundreds of thousands of various products. And when you have that complex of a system, you can never expect to have 90 days on hand inventory for 50,000 products, first of all, but you can't even really manage a small fraction of that on any sort of routine basis. So we've had to really, focus and dial in, and truthfully have some difficult conversations with physicians to say, what are the 5, maybe 10 products that would close your department down, or would have dramatic implications to patient care if we did not have it. And it's always the running joke is, when you ask a nurse or doctor what products are critical, the answer you get is all of them are. Well, again, it's getting it down to that critical few, and then putting eyes on specifically what's happening with the industry, the vendor, the transportation route, and being able to get down to a really granular level to predict when the next shoe is going to drop. And then if there's some suggestion that we may be either we know we have a stock out, we know we have a back order, or we think we might, then figuring out what the reasonable alternative might be for that product. Can a small instead of an extra small work in a pinch? Can we get and this is this is tongue in cheek, but can we acquire the blue widget instead of the red one? Does it really matter? Those are the conversations that we have to start having. So in general, that's kind of how we manage it.
So the next kind of set of questions I have relates to moving forward, but is there anything you want to say with respect to the changes and how things have, the state of things now before we move on? Yes, I would add one thing, and this is maybe bringing it back to real life. One of the other running jokes that we have as a supply chain division right now is order your Christmas gifts now or don't expect them to come. And even though we say that jokingly, it's sort of true. I expect that the exact same global supply chain issues that are impacting healthcare are or will begin impacting just regular human goods. And I think we ought to expect, just as human beings, to see less choice, more price, or higher price, I should say, and expect. A lot of us have started to see delays just with consumer goods as it is. Products that say they're shipping that really haven't ever shipped anywhere, are still sitting in Asia somewhere. We ought to expect that, and I think that's going to be something that takes all of 2022 to work itself out and work itself through. So, just as most of us are consumers, I think that we ought to expect that that's going to be the case for a while. So then pivoting into what it's going to look like, how has, let's say, risk management, generally speaking, in the supply chain, how has the thinking changed for you? What practices or policies are you all implementing now to prepare for the next one of these that you didn't have in place before?
Yeah, there's a few things that are happening. I think the first thing that I'm seeing, and again, this is a Mayo Clinic lens, but I suspect that we may see it more globally across healthcare supply chain. The first one is less of a reliance on a distributor relationship. And we rely, as do most, heavily, especially our two southern campuses, Jacksonville and Scottsdale, rely heavily on our third-party distributor. And while there's value in having that relationship, what we learned was that during COVID, there was very, very little value in that relationship, because what happened was vendors were saying, hey, look, we're at highest levels of capacity to get you the stuff you need. And the last thing that we need right now is a third party being in the center. So we want to talk directly with the healthcare organization, not a distributor. And further to that, we will drop ship the products that you need. We will not go through a distributor because we don't need one more set of hands touching this product and messing it up. So what we saw was, during kind of the throes of the PPE crisis, was distributors basically stepping out of the middle and letting the hospital organization communicate directly with the vendor. Now, that has in turn posed a lot of questions to hospitals to say, is there long-term value with the distributor relationship? And I would argue there are still some perks. But what Mayo is looking at, and we've not been quiet about this isn't confidential, we've basically said, we're no longer going to rely on a distributor to ensure that we have products. We are going to move to a self-distribution model. And what that likely means for us is having, currently we have a large inventory center in Rochester, Minnesota. It services primarily just the upper Midwest locations, but we're saying no longer will that be the case. We are going to, whether that's a center of the United States distribution center that can work as kind of a spoken hub and service all campuses, or if it remains in Rochester, regardless, we're going to become self-reliant on ourselves instead of a third party to manage inventory, move inventory, all of those things. I think that that's a possible outcome, as it relates to future healthcare organizations and supply chains. But the only way you can do that is to have really crisp, really clean, and very timely data, both from the supplier as well as your own utilization data, to be able to do something like that. And that's the reason that distributors have always been successful, is because generally speaking, their data is way better than the hospitals is. And that's how they can detect demand signals. That's how they can determine what products are likely to be needed and when, and that's how they stock their warehouses. So what hospitals are learning is that the concept of stepping away from a distribution model sounds good on the surface, but if your data is crap, then that doesn't work. And so hospitals are spending a lot of time now trying to figure out how they either create the data that doesn't exist or cleanse the data that they have so that it's usable. So those are a couple of the trends that I'm seeing.
That's not unique to healthcare too. I was having a conversation with somebody in the restaurant hospitality business earlier in the week, and they're a major restaurant chain with several locations throughout the country. And they, prior to COVID, had gone to a self-distribution model. So they had their own distribution centers geographically distributed throughout, servicing, and not all of it. They relied on vendors for some of it, but that was what allowed them to weather COVID in a way that other potential competitors hadn't. So that's interesting to hear that. So I've got one more for you, and then I'll kick it over to the audience. So you talked about basically reducing dependence on distributors as a big thing you see moving forward, and reliability of data and the need for that moving forward. Is there like one thing that your organization is just solely focused on in terms of the next 15, 20 years, outside of anything we've spoken about? Is there like, what's the goal of the supply chain? What would be the supply chain of 2040 for the Mayo Clinic kind of thing?
Yeah, and actually this had started before COVID as well. Our organization, Mayo Clinic as a whole, as an entity, as well as Mayo Clinic supply chain, have been moving toward a digitization strategy. And what that means for supply chain specifically is basically, I hate to say taking humans out of the equation, but a lot of it is, moving transactions that are nowadays not so much paper, but in the old days were paper, now more EDI types of transactions, but moving that to a digital platform. And one of the things that I think is unique about digital that doesn't exist today, or it's at least in healthcare supply chain, is that it connects lots and lots of nodes together to come up with particular insights. And I'll give you, I can give you an example from some of the resiliency work we're doing. We have a new tool that we're piloting right now that, and again, this looks just very specifically at supply resiliency. But we have I would consider it something similar to, I equate it to Slack, those of us that have used Slack before in the office, where there's different conversations and work streams that are happening within the different channels. Conceptually, that's how this would work too. And basically, it would allow us to pull in things like FDA actions, weather events, geopolitical events, and layer that data on top of things such as vendor advisories. If vendors push out communications, public information, not stuff that we're scraping illegally or anything, but vendor advisements, things like trucking disruptions, bottlenecks at ports, all of those, bringing all of those components of data together to then give us intel into what's happening right now and what's likely to happen tomorrow, a week from tomorrow, a month from tomorrow, and being able to bring all those data components together. So supply chain is working aggressively toward that digital strategy. And you said 2040, our goal is 2030 to have really everything scaled. And again, that's institutionally across all of Mayo, not just supply chain. That's a big one for us. And I think that will, if it's done right, I think that will enable us to take a lot of that administrative burden off of humans, place it on a computer, for lack of a better term, and then be able to pull in those insights that help us to be more predictive instead of reactive.
Great. So I think we've got one question here in the chat, and if anybody else has questions, feel free to pop it in. The first question is from, oh, hey, is that Ryan? Hey, Ryan, how are you? Ryan wants to know if the Mayo Clinic is doing anything to forecast shortages at the tier 2, tier 3 level to combat this whack-a-mole that we've been seeing with the shortages. I mean, what's the role of forecasting in your organization as it stands currently?
Yeah, wonderful question, Ryan. That's very insightful. Getting down to second, third, and n number of tiers in the supply chain is really tough. It has taken us 5 years to just get to level 1, to just get our manufacturers to tell us where they produce products and what products they produce there. And it has only happened where we've been able to map even just manufacturing locations, because dozens of healthcare systems have come together in a collaborative and said, we're not asking nicely anymore. We're telling you that we require it. And next step to your question, Ryan, is that's exactly where we're going next. So, we started off this exercise again 5 years ago in saying, we want to know where you make stuff. that's the non-technical term. We want to know where you make stuff. And the next level down will be, okay, where are your suppliers making, acquiring, growing, whatever their stuff? And then what are their suppliers, working down in the supplier chain. We're a long ways away. We're way behind what, grocery, food, banking, all the other, major industries. We're way behind where they're at right now. And I think it probably will take, hopefully not 5 more years. I'm going to guess 1 to 2, probably more like 2 to 3, to get level 2 and then level 3 and et cetera data down to that granular level. So the whack-a-mole will continue for a while. And quite frankly, at the moment, everybody is so distracted with what's happening just right in the backyard, the Port of LA and San Diego, that I don't think anybody will focus on this topic, but it's something we'll have to come back and look at closely.
Great insight. Any other questions from the audience? Please feel free to chat them in now. If not, we might be giving you back 26 minutes of your, oh, we've got one. All right, go ahead, Tony. Sure, yeah, please feel free to hop on video.
Okay. Hi, I'm Tony Sampanero. So I'm an RIT alumnus, soon to become a student again at the Saunders Executive MBA program come January. Very excited about that. So I work in the pharmaceutical and biotech industry right now, and we've been facing supply chain issues as well. So one particular problem, besides just common lab supplies, is when we have regulated material that needs to be shipped. So for clinical trials, things like that, that could be drug product, or it could be, for example, tissue samples. That requires, white glove handling, typically through, specialized carriers like World Courier or BioCare. I was just wondering how much that affects your business there, Erich, at Mayo Clinic, of those, custom and critical types of materials, and how you're, handling that.
Yeah, really good question. And pharmaceuticals have been, even again before the pandemic, we had seen critical shortages of specific drugs for quite some time. So the pandemic just heightened that issue. So we do have a large both research and lab presence, primarily in the Rochester, Minnesota area. And we have experienced and continue to experience a lot of issues in lab. Not so much. I think what you were describing was more of a courier type of issue, but we have experienced very, very difficult shortages of products in the lab space. And unfortunately, as you probably know, in the lab space, there aren't a tremendous number of alternatives because of the regulations around what you can and cannot do in that space. And so unfortunately, there's not a lot of alternative substitutes that we can use when we run short of lab supplies. But we have seen, and I couldn't tell you the specific supplies because I don't understand half of them, what they do, but I have heard of severe shortages in the lab space, and especially the last month or two. And you're right in terms of how they're handled and who can handle them and chain of custody and all of those things. That does nothing but add more complexity to an already pretty complex area of supply chain as it is. So yes, we have seen the same. And from what I've heard from colleagues in the lab space, we should expect that to continue for foreseeable future.
Yeah, thank you. One other detail I'll add is that, for regulated processes, for drug substance or drug product that I deal with, one particular shortage we've come into contact with is filters, particularly the types of specialized filters that you use to sterilize things. If you can't autoclave them, there's a sterile filtration. And if your process is validated, that means that it's validated for, under a very specific set of conditions, including right down to the make, model, brand, et cetera, of that sterilizing filter. And I've run into this issue myself where, you can't find those filters anymore. So now you have to go back and revalidate and requalify that method or whatever it is, with the new brand of filters, and then file, an amendment to your regulatory, paperwork on top of that. So something as simple as, oh, we can't find brand X filters, let's substitute brand Y, has, many, many knock-on effects.
Yeah, absolutely. And that's one of the challenges and why lab is so different from, your traditional clinical practice. I gave the example before of can we just use the red versus the blue. In the clinical setting, that's less of a risk and less of an issue. In the lab space, you're absolutely right. You have a specific set of guidelines that you've already gotten approved and gone up through whatever board or body that requires, and then you have to go back and start over at square one. And that creates tremendous churn in the lab when that takes place. So you're absolutely correct. The magnifier effect of a shortage in lab is probably tenfold over that of just a what I'll call a regular practice area. So Absolutely true.
Yeah, great. Thanks very much.
Thanks, Tony.
Absolutely. Thanks for the question.
Well, I'm not seeing any other questions pop up, but I'm going to give a big thank you to Erich and let him get back on the long drive. And this recording will be available to everybody if you'd like to come back. But Erich, thank you so much for your time. I'm sure everybody, including myself, appreciates it. And everyone who joined, thank you again. This was brought to you by the Masters of Global Supply Chain Management program at RIT. If anybody has questions, feel free to reach out. But have a great rest of your weekend. Take care.